we'd like to share with you today is a lot of work that we did on alternative methods for reaching vulnerable workers. It was a pilot evaluation of pictograms and training, specifically in the restaurant service sector. And this was really a collaborative effort between Institute, WSPS, as well as an MSD strategically. On the research team, there was myself and Kim, as well as Sheila Huff-Johnson and Saladin Ibrahim, who really helped us out with stats that we thought were going to be fairly straightforward and quickly got very messy. Thank you very much for that. And then other researchers in the project also included Yvonne Steenstra and our scientific director, Ben M. So today, what we'd like to cover is just some background on the project. Then we'll dive into the development of the intervention and the evaluation. We'll share some of the results that we had. And then we'll get into some of the discussions around some of the issues that we had with the project, as there were quite a few, being a workplace intervention study. And then finally, we'll wrap it up with some conclusions and looking forward. So first, we thought we should perhaps tackle what is pictogram. And a very brief description or explanation of what a pictogram is. It's a visual representation of an object or an action. They tend to be used to indicate prohibited or desired actions. They're often seen on chemical hazards, medicine, consumer products, things like that. They're often used as warning labels, mostly because they're thought to be a universal language. This is a bit of a dicey concept because we know that there are certain things that influence how well a pictogram is taken by an observer or how effective it is. And things that affect that include cultural differences, age, as well as a familiarity with the product or the object or the action. Also, there's quite a bit of work around how effective pictograms are, and that relates to a number of different things, from the noticeability of a pictogram, how well it's recalled or understood by the intended audience, as well as compliance. So that image there, that's actually an image that I took while I was abroad in Ireland. Ever since this project, whenever I travel now, I'm completely consumed by pictograms and I'm constantly taking photos. So this one was at a beach, and it was a bit of pictogram overload. I didn't even get all the pictograms that were on there. But it's somewhat unique because later on we talked about matching pictograms with their sort of hazard scenario, or the undesired behavior or practice, and the desired practice. And this was a really good example of that right off the bat. So sort of no dogs or coyotes or whatever that might be, or at least, but without the leash. And so then here's what the desired action is: if you're going to bring your coyote to the beach, make sure it's on that leash. Okay, so some background on the project. Where did this project come from? Well, the WSIB funded a strategic collaboration, and I mentioned it was with the HSAs, IWH, WSIB, and the Ministry of Labor, which created this MSD task force. And it was to develop an alternative method for reaching vulnerable workers from MSDs in various work sectors. And when we say vulnerable workers, we're really referring to workers who may have English as a second language and or low literacy skills. So potentially people who are not going to uptake health and safety information in a written or verbal format. So the Workplace Safety and Prevention Services, formerly known as the Ontario Safety Service Alliance, took the lead on the development of pictograms for 4 service sectors specifically: kitchens, warehouses, greenhouses, and the retail sector. An evaluation component was needed to anchor this pictogram development in evidence-based application. So we're creating this intervention, but we want to know that it works. We want an evidence base on this. So I think I'm going to hand it over to Kim and talking about just where this all came from and how it actually became a developed product.
So when we received the funding to do the project, there was a request for restaurants specifically, but we had enough funding to do a variety of different sectors. So we did an analysis. We knew we were working in restaurants, but we did some statistical analysis and looked at our client data at OSSA and our partner organization, IAPA, and identified the other sectors, so the greenhouse, the warehouse, and the retail, as areas where MSDs, we were focusing in on MSDs, where those injuries were significant and there were items that we could work with. While we were doing that, we asked the IWH to do a systematic review of pictograms and visual learning for ESL, and we completed a standards review. So we looked at all the standards that we could find related to developing pictograms or visual symbols. We received input from our project team and ergonomic advisory committee as we went along through the process. So even though this is sort of drawn as a step-by-step process, there was lots of going back and forth between the different boxes. So we started getting input on the risks that we had identified and showing that to our ergonomic team, and did they agree? Were they surprised by the findings? And they gave us some input on that. And then as we started getting information from the systematic review, they also started reviewing that. So once we had decided specifically to move ahead in those sectors with the hazards we identified, from the literature in a systematic review, we found that pictograms might be more effective if you had the hazard, but also showed the control. So that's specifically where we ended up going, is developing hazard and control pictograms to tell the whole story. And our funder was very interested in that as a way to proceed. So once we had all of this information, we knew which standard we were going to follow, and we had our systematic review data, and we knew the hazard areas we were going after. We set out an RFP and engaged designers to actually start developing pictograms for us. When we were developing the pictograms, we wanted to test them with actual workers in the environments. And the image on the left of the screen, or the right of the screen for you, shows a little bit about how this process worked. So we originally developed 59 different pictograms for the hazard areas in restaurants and tested those with 4 focus groups that came from a variety of restaurant environments. So we had large restaurants, we had some smaller restaurants, we involved cafeteria workers, and we either went to their environment and tested the pictograms right in their environment, or we had them come to the CHSI. So the diagram shows, these are just a few of the ones for the chopping hazard. So along the top, we wanted to indicate the use of the knife to chop, and that the time is doing it for a long period of time. And in the original focus groups, the first couple of focus groups, they didn't get either chopping. We weren't doing the chopping right in the picture. The arrows don't indicate how that actually happens in a restaurant. And the clock didn't mean anything to anybody. They didn't know why it was there. So the next round of pictograms, we put the gray, I don't know if you can see it, but there's gray to indicate that you're doing it for most of the time. And then we reversed it and used the green. And we had a chef actually inform us of how we should best draw the chopping. So they leave the points of the knife on the chopping board when they chop. And they really liked, the next round of focus groups really liked this change. They understood that it was chopping, still had trouble with the clock, and a decision was made after the next 2 focus groups that we were actually going to go a little bit outside of the standard and introduce a new color, and that's the red, which means that you're stopping for a short period of time rather than focusing on working for a long period of time. These are actually control pictograms, so they're trying to demonstrate the right way to do something. So I'm going to show you the pictograms that we came up with. The first one, area of focus in restaurants, was chopping. We went with the typical hazard symbol, so that's a triangle with a yellow background. We tested a number of variety of ways to show pain. So we had concentric circles, we had dots, we had stars, and the workers liked stars the best. They felt that showed pain And they liked this picture of chopping because that's definitely not how you would do it. So it's not how they see chopping, but they could see that that represented a hazard to them. And then there's the control. So holding the point of the knife on the board to chop and taking breaks is a way to alleviate the stress on the arm and having the right wrist motion. This is the second set of pictograms, and this is about handling large containers of food. So when food arrives in a restaurant, it comes in, big bags of potatoes or carrots, and they have to transport this food to the cooking areas. And when we went out and tested, so there's our hazard pictogram, and they're lifting up the container and trying to carry it. When we were testing the control pictogram, we had a series of ones with different kinds of carts and other methods to move the material. And the workers said, well, I don't ever transport that from the storage room to where I work. I work in a hot area of the kitchen, and I transport it in a different kind of container. So they come in different kinds of containers. So we ended up actually having a generic one for if you're moving from the storage room, moving hot food, and for cold food. So there's a sink and different kinds of tools that they would use. So they really influenced this one in that we actually needed different control pictograms depending on what part of the prep kitchen you worked in. And this one was about moving prepped food. So once you've worked in your area of the kitchen and you've created some food that might be going to another part of the kitchen to work with, that's what this process is talking about. So they tend to chop the potatoes or chop the salad, and it goes into another container that's still fairly large, and they transport those to a different part of the kitchen. And this hazard is showing that they're using a large container and carrying it, and the control is that they've used smaller containers, and they're carrying those smaller containers instead of the heavier weight.
And is the position of the containers relevant to the ones down?
This is showing that the container is being held out from the body and far away, and this one is that it's being held closer to the body, but we also left that there needs to be vision. So they have to be able to see over the container. This pictogram, and this is something that we saw less of than what we were expecting, but it is a hazard that comes up a lot in hazard reports in restaurants and lots of other sectors where they store heavy things on high shelves rather than more accessible. So this hazard is showing that the heavy item is stored on a high shelf and they're reaching above all the time to get it. And the control pictogram is showing that the proper way to store a heavy item, you should store your heaviest items at your waist, and there's a cart there that they can slide the heavy item onto. Okay, before I go into that, I just wanted to say we actually, in the training, shot video that shows the hazard and control pictograms, or the control pictogram, to help reinforce the learning. We don't have a sample of that. So the next step, once we were in the process of developing the pictograms, was to develop the corresponding training. One other thing we learned from the systematic review was that pictograms tended to be more effective for those ones that were measured, and there wasn't a lot of information about that, but they tended to be, or there was a belief that they would be more effective if they were accompanied by training. So we started to create training and share it with workplaces to test it out. And the top part of the screen on the right is the original draft of the training. And the language level tests at about a grade 9 level. And the bottom slide shows the exact same slide, but in the finished training, and that's testing at about a grade 6.8. So not quite a grade 6 level. We found that when we tried to use the original training. And MSDs are particularly hard to bring the language level down because the content is very technical. So we thought we had done a good job. And when we first went out with the training and had that content, the first class had no idea really what we were talking about, and they were really struggling with the content, and we had to spend a lot of time explaining what was going on. So that wasn't working for the group, so we had to change it. So we went through the entire training program, brought the information back to Trevor and Ben, and went through the program and brought the language level down. And we used Flush Kincaid, which is a way to test language by number of words in the sentence and number of syllables in the word. There's a formula that you use to figure out what the reading grade level is. So here's the objectives of the employee training program. We focused on getting employees to identify specific MSD hazards in prep kitchens. So it wasn't a generic kitchen training program about MSDs. We were very specific about the hazards that we were talking about. We wanted them to be able to explain what they could do to reduce the risk of being hurt, and we showed them the hazard and control pictograms. We had them talk about where they could get help at work after we left. So who should they go talk to? What are their company procedures? And we had them talk or make a sort of an action plan about what they would do personally to avoid injury at work. We added on a half-hour session, so the supervisors also got the employee session, but then they got an additional half hour that focused on where and how to place pictograms in the workplace for most effectiveness, and understand how to provide coaching and support to staff after the training. So we spent that time, basically we showed them what the standard said about posting, and then we spent about 20 minutes coaching them on how to coach their employees about the pictograms.
So then we decided, how are we going to evaluate this? We brainstormed a bit, and we felt that pre-post design with control intervention groups would be best. Our outcomes of interest included a change in knowledge, a change in work practices, and a change in symptoms. We started out with an okay sample group size of about 61 participants. At our first follow-up after the intervention, that dropped down to 51, and then we definitely saw quite a decline at our second post-intervention measurement point, down to 38, and I'll get into why we saw such a drop. This is a timeline of the evaluation protocol. So here at 1 month before the intervention, we went into the workplaces and we were measuring work practices and symptoms. 1 month later, the intervention was conducted in the intervention groups. And surrounding that, we did an immediate pre-post knowledge test to measure knowledge. 1 month later, we went back into the field and we did the same measures as we did at T0. So again, looking at worker practices and symptoms. And then we went back 1 month later for the same measures. Now, overall, this is actually quite a short evaluation. Typically, we would see something a bit longer and a bit more thorough. However, we were really restricted by budgets and timelines for this project. It was originally thought was going to be maybe a 4 to 6 month evaluation. Quickly turned into about a year to a year and a half. And a lot of that was just coordinating with the work sites and getting the numbers that we needed at each site. So again, in terms of our outcomes of interest, we had to create measurement tools or find measurement tools for each of those areas: knowledge, worker practices, and pain and discomfort. So with the knowledge test, that came from it was adapted from an office ergonomics knowledge test that had been previously used and validated in actually the big chair study that Dynamic was a part of quite a while ago. So it was that specifics of that test was published in 2009. There were 14 items in total for this evaluation. There were 9 questions on MSDs and 5 on the pictograms specifically. The breakdown was true and false and multiple choice. We didn't want to leave any sort of open-ended questions where participants were required to write out lengthy answers, given our population. And then it was also adapted to a 6th grade reading level, where possible. This was a lot more challenging, so the worker practices, how were we going to measure this? We wanted to capture the change in worker practices from the number of risk practices compared to the number of control practices based on each of those pictograms that we saw before. We were unable to find a really suitable tool from the literature, so we created one. And in doing so, we consulted with experts in the field as perhaps the best way to do this. It was a suggested method from Judy Village. She was at West. She's currently at Ryerson doing a PhD, and she did a lot of work in assessing custodial workers at universities and schools who have sort of a range of tasks throughout the day, all quite physically demanding, and they created a back exposure sampling tool. And the details of that tool include capturing activities, sort of a snapshot of what the individual is doing at a point in time, once a minute, over 7 hours. So it's sort of a poor man's way of video capture, if you will. You're really just catching little individual pieces of time, and then you're extrapolating it to be representative of perhaps the whole day, or whatever time period that you were looking at. It sounded like a great method for what we wanted to do. However, once a minute over 7 hours, there was some problems. There were definitely time and budget restrictions around that, as well as that's quite a high observer burden to stay vigilant once a minute over that amount of time. So we adapted that method to once a minute over 30 minutes. That's quite a reduction. So we also did that over 3 days. And at each of the days, we looked at a different time period of the day. So we're catching a range of duties. And then we also, that covered the 3 observation points that I discussed earlier. So T0, T3, and T4. So this is just a sample of the tool. So we sort of broke up the tasks up top and paired them with their specific pictograms. And then we broke down all of the specific tasks that could be incorporated in doing any one of these actions. So is there a neutral back posture? Are they using a cart? Are they portioning out items when they can? Are they using the correct wrist technique? Are they using the correct finger technique? All of those items. And if they are, then it would be recorded as perhaps a C for the control behavior. And if they're not, it would be recorded as H as the hazard practice or behavior. For capturing pain and discomfort, we decided to use a modified Nordic musculoskeletal questionnaire for musculoskeletal symptoms. Basically, just a body map with each segment, or with the body segmented, and then the individual scores on a verbal scale. And we realized this was a problem quickly into the study. Whether they have no pain or discomfort, all the way up to severe. The participants were asked to fill out the date. They were each given a unique ID number. They were meant to indicate whether this was at the start of the day or the end of the day. We asked them to complete this at both times so we could see if there was a change in pain and discomfort over the day. And then we asked them to fold it up and put it into a ballot box in a workplace. And that didn't go so smoothly, and I'll talk about that a little bit later. So in terms of the knowledge tests, getting into the results, we did see an increase in knowledge among the workers in the intervention group. So the pre-intervention mean, as you see, was 81 roughly. The post-intervention mean was on the high side of 92, so about 93, and that was statistically significant. So we were happy about that. And we sort of expected to see that. If you test people right before, you give them a training, you train them on very specific material, and you give them the exact same test immediately after, you hope that they were awake long enough to pick up something. So.
And they were?
And they are. In terms of the work practices, so this is where the data got quite messy. We decided to look at 2 ways of assessing it overall for all tasks combined, and we weren't seeing much. And then we decided to assess independently for each pictogram-related task. And we wanted to know what there's statistically significant difference between groups in the ratio of hazard practices to control practices at each of those observation time points. So for chopping, in our first analysis, we see that there was actually a difference at baseline, so that wasn't great. The control group seemed to have more risk practices than the intervention group. moving into the next data collection period, we saw that difference decrease or vanish. So that no, there was no more statistically significant difference between the groups. The control had actually reduced their number of risk practices, whereas the intervention group had stayed roughly the same. However, at T4, the intervention group had dipped off quite a bit, and the control group had picked up slightly. So yes, we did see a difference by the end of the study. However, you can see that there's some mixed results in here. And then Ben had the great idea, well, maybe we're seeing differences because perhaps we had that large loss to follow-up. A number of people dropped out through the study. Well, those people who dropped out, do we know what their risk practices look like at baseline? So the people who drop out, they have more risk practices than those who remained in the study, and is this perhaps accounting for some of the differences that we might be seeing in our results? So we went back and looked at that, and for this particular task, there was no difference in the risk practices at baseline between those that remained and those that were lost to follow-up. So that was good news. For general prep food handling for the hot and cold, specifically, this is how we broke it up. So at T0, there was no difference between the groups statistically. At T3, there was, and at T4, there was. So we were quite happy about that. We started to look again at the difference between those lost to follow-up and those that remained, and there was no difference between those groups at baseline. So again, this was another win for the intervention. However, looking at some of the other ones, so for general prep food handling, apart from the specifics of hot and cold prepped food, there was no difference at the start, and we did see differences after. However, there was a statistically significant difference in the practices between those who remained in the study and those that were lost to follow-up. So we're not completely confident that these differences were due to the intervention. They may have been, in fact, that those with risky behaviors dropped out of the study. Looking at moving prepped food to the cooking area, we didn't see a difference at any time point. That we went ahead and looked at whether or not there was a difference between those two groups, and there was no difference. Speaking to this, the reason why we think we didn't really see a difference at any time point was, so I was the one doing the observations in the field, we just didn't see, or I didn't see, a lot of this practice being done. So there wasn't a large enough sample size to show any difference anyway. Looking at storing or retrieving food, again, we didn't see a lot of this, and a lot of places seem to have good practices to begin with. There was no differences between the groups at start. There was a T4, or sorry, that should be T3 and 4. So that should be T3. And there wasn't a T4. There was statistically significant difference in risk practices between those that remained and those that were lost. So again, we weren't confident that this one difference here was due to the intervention. It very well could have been due to our loss to follow-up. In terms of the daily symptom survey, we weren't sure what we were going to see here because we were looking at things in such a short period of time. We thought that we may have seen a decrease in pain and discomfort, but we weren't completely confident. When we first looked at the data was definitely positively skewed, so meaning that very few people had any high rankings of pain and discomfort. Many people were reporting zeros, ones, twos. So we log transformed the data for analysis, and then we also decided to group the data by body part. We figured that if we were going to see a difference, it might be in the upper extremity, then perhaps the upper body, and then we wanted to compare that also to the total body score, so that we added up all of the items on that body map for the total body score. Was there a significant change in pain over the day? So just before we got into anything, we wanted to know, are we seeing an increase in pain over the day in these workers? And yes, we were.
Whole body? Whole body?
No, sorry. So it's not for the whole body, but specifically yes for the upper extremity, not for the other two variables.
Okay.
So then we dived a little bit deeper. Was there a significant difference between groups in their average change in pain scores? So looking again at the end of the day, subtracting the start of the day, and then looking at it over the 3 days of observations for each of those time points, T3 and T4. And no, we didn't see a difference between our groups, so that was a bit discouraging. And then we decided to look at it a different way. Sally got very creative. He said, well, maybe we're looking at this the wrong way. Maybe we need to look at it more of a dichotomous variable. Perhaps see if symptoms are remaining the same or improving, compared to those whose symptoms worsened. But even with sort of that fancy analysis, we still didn't really see a difference. We were quite close at T4 with 0.05, but we weren't confident to say that there was a significant change or difference.
Were you finding differences that you thought might have been meaningful, but they weren't statistically significant, or were you finding that there was no difference in the?
We did, yeah. So I mean, like this is a good example of that. Like we thought that we would have seen some sort of difference. We thought we were going to see a bit of a decrease. It wasn't strong enough to be statistically significant.
So double the sample size, right? Mm-hmm.
So definitely recruitment was a challenge. Locating the sites was quite difficult. We were doing it on both ends, IWH and Workplace Safety and Prevention Services. And I think we ended up, when we said we have to get going on this, with a total of 7 sites. And 5 of those 7 sites originated from a parent corporation. So we were quite thankful to that parent corporation. However, it did introduce this selection bias. However, going into each of those locations, we noticed that each of those locations were quite different in themselves. Just the workplace culture at each location, even though they did have sort of this parent corporation that has their head office health and safety protocols and procedures, they weren't necessarily being carried out as intended. The location of the sites was definitely a factor. So there were people who were interested, but they were actually just too far for us to get to feasibly with our budget. A minimum size was necessary at each site to make the travel and time worthwhile. Again, we had a couple of sites that probably could have worked, but there was only 3 people in the kitchen, and that would have taken up just too much time to record their observations. And then the few sites could afford the time required for the training. So people were interested again in the study, but they didn't want to really release their employees for an hour and a half training. In terms of the participants, there was limited understanding during the recruitment process, definitely. As we went to each of the sites, we spoke with the potential participants in a group. We read through the consent form, tried to make sure that everyone understood what was going on. And in the end, as we were well into the project, I would still have people coming up to me asking what the purpose of the project was. So obviously they didn't catch it the first time around, which was a bit scary because they did consent to the project, which also meant that they didn't understand the consent form either, because it was quite laid out in the consent form. However, that consent form read much more like a legal document than getting someone interested in the study. So that also scared a number of people off. And then there was also confusion over who we were or who I was. So a number of times people thought I was from the Ministry of Labour or WSIB, and I had to keep reminding them that, no, I'm from the Institute for Work and Health. This is a research study. I have nothing to do with your claims or getting things changed within your organization. And then there was also just this factor of low trust. So there was definitely in our recruitment, you could tell the sites that we had quite a number of people interested in participating. They had good manager-employee relations. They were friendly. They interacted. There was sort of a family atmosphere. And then we went to other sites where there was opposition right from the get-go, sort of a back and forth between employees and managers. And then obviously we had very little people participate because it felt like it was coming from management. We had this loss to follow-up. It was 61 at the start, 51, down to 38. So we can dive into that a bit. One of the sites was removed from the study after failing to post pictograms 2 months after the training. So that sort of ruined our study design. And so that's where 5 participants were lost. Another site posted the pictograms 1 month after the training. So they obviously didn't attend that manager component that instructed them how or where to place the pictograms. That was the reasoning for the 1 month delay. So we kept them in the study. We just recorded their observations as T3, which meant that they had no values for T4. So we lost another 7 participants there. Other participants were lost for just various reasons that included seasonal changes, a change in the number of customers in the kitchen. So they had less work or different work. There were semester changes. A number of these sites were at university or college cafeterias or restaurants. So students, and a number of those places had students employed. So once the semester changed, they had different duties and priorities, and perhaps weren't working in the kitchens anymore. there were schedule changes in duties. That often there would be times where I might walk in at T3 or T4, and someone who was previously doing a lot of prep kitchen duties was now maybe on cash or somewhere else in the organization. And then there was just a general high turnover, so we lost 9 more participants to all of those factors. And then we have the intervention. Do you want to talk to this?
So when we went to do the intervention, we had resisted to the 1 hour training or the hour and a half training. People were saying, you know, I've been here all day, I want to go home, my bus is coming, I have to go. So there was a lot of pressure to reduce the training to be under an hour. And the employers were not required to actually stay for the duration of the training. So there was a couple of sites where people were actually getting up and walking out because their bus was coming or they needed to be somewhere else. Well, we encouraged the managers and supervisors to stay and attend the training and participate in the management training. That was even more difficult than just keeping the employees in the room. So in some cases, they showed up for the introduction and told their staff, you know, here's this great training, I'll be back, and we never saw them again. So that posed a bit of a problem, and it showed up later when Trevor went back to actually see what they had done with the pictograms. And getting them to participate in the pictogram, like putting the pictograms up, was also challenging. There seemed to be a lack of understanding on their part of where they were supposed to post them, and lots of questions after the training. We were actually called as the deliverers of the training, saying, "What do we do with these pictograms? Where are we supposed to put them up, and where do they go?" And then Trevor would get asked as well. So there was lots of challenge around the training. And this is something we hear from our consultants all the time. So it rang true. It was just an interesting experience from someone who typically develops the training and doesn't try to deliver it. So it was a good learning.
So we definitely had some challenges with our measurement tools. We thought they were great, and perhaps they weren't as fantastic as we had hoped. With the knowledge test, again, with the limited time to complete them as intended, we felt that might have affected some of the scores. And despite trying to lower the reading level down to a grade 6 level, there's still some difficulty in comprehending what the test was asking.
Trevor, how much time did they have to complete the knowledge test?
The last 15 minutes of the class, they actually, we left quite a bit of time. And around the difficulty and comprehension, while they were, even though they had done it as a pre-test, and we had just trained them, when they were writing the post-test, they were still asking questions about, you know, what does this mean, and what am I supposed to do?
So 15 minutes was a struggle.
It was a struggle.
Okay.
In terms of that observational tool, it's not always easy to follow the employees through a kitchen as intended. There's very tight spaces in kitchens, and especially when it's a rush hour, whether it's a lunch or dinner, the employees are moving around quite quickly, so you can't tell what shadow someone is intended. As well as trying to make the fact that you're watching someone unnoticed isn't always easy in quite small kitchens. And then there's also just unexpected change in duties. So someone who might have had a lot of chopping duties one day, the next day when I go in, they could very well be sweeping the floors for the entire day. So nothing to do with pictograms whatsoever. With the daily symptom survey, or the daily health diaries, we called it, again, there was limited time to complete it as intended, or at least this was reported by the workers. Looking at it, it was just the body map, and you rate your discomfort for each body area. And typically, if you were to do that online, it might take about 30 seconds. But many of these people were in a rush to get in a rush to get out. They didn't really want to spend another minute filling out this form. And then we did have individuals who looked at it and they said, "What is this? What does this mean?" Because we totally forgot the population that we were working with, and we had listed all of these body parts by name with all these confusing lines, and then we only used verbal anchors. So again, people didn't really understand this scaling system that we were trying to get them to use. What we ended up doing for those individuals in both situations, the time restrictions and just the comprehension, was doing it in sort of a one-on-one interview. And once I'd been in the kitchens long enough, people knew who I was and were familiar with me. They were much more comfortable doing it in that manner. They could go about their work, and it didn't sort of pin them out as anyone who had trouble with the survey. It was just an easier way to do it because they could continue their work, and I get my data collection, and we both go our separate ways.
So Trevor, like there was no really sort of formal training behind the filling out the daily symptom survey?
No, I wouldn't say there was formal. Again, sort of. So on my first day, I would come in and say, "This is what I'm here for. If you see me around the kitchen, we're going to ask you to fill out these surveys." And I went over how to fill it out. Okay. But again, it was just sort of as a group discussion. It was never anything intense. There was no PowerPoint, and it definitely wasn't a one-on-one. So moving to that format definitely works better for certain situations and certain individuals. And then there was also, I mentioned earlier that we were asking them to fold it up and put it into a ballot box that was located in the work area. Many employees were not having that. They felt that at any time management could access that box, go through the surveys, and identify their handwriting, and do something with that information. Cool. And this was a sensitive issue that we hadn't even considered.
Yeah. And we didn't include the daily symptom survey in the training at all, so we didn't talk about it. We just focused on the pictograms and what they meant, and that we were really focused on that in the training. So we didn't talk about the research study in the training that much. We mentioned it, but it was a light touch.
I guess if you're limited on time, it's hard to determine how much to spend on what, right? Like because I'm an ergonomist, whenever I get involved with doing these types of surveys, we spend a significant amount of time on the survey. But that's because we have it, right?
Right, yeah.
So I guess there's a time constraint there, so that you're dealing with.
Trevor, can I clarify something? So
yes,
if I heard you correctly, then the way that the daily symptom survey information was collected is different in the subsequent time points than in the very first, because it was only after you got to know them that you started interviewing them, or were you interviewing them right from the first?
The interviews started in the actually the very first site. So this is where
we didn't really change.
Yeah, realized it. So I think originally we wanted to spend about a full week at each site, and then within the first 2 days, I had a total of maybe 3 surveys in the box, and so quickly reported back to Ben, this isn't going so well. I think we need to change our approach.
Okay.
And that's when we started, and then we also altered the length of time at each site to 3 days to try to accommodate.
But at least then the delivery or the collection process was the same in all 3 time points, as opposed to changing return.
Yes, however, I would still say that it was mixed, because there was employees who weren't completely comfortable filling it out and leaving it in the ballot box, whereas there was others that I knew that I would have to go to approach. Okay. Yes, Sheila.
Were MSDs seen as an issue by the management and the workers, or the workers?
So the parent corporation, definitely yes. So they were excited about the research study. They and this goes a bit to the bias in the study, is they selected the sites that we were invited to go see, and those sites were their poorest performers. So they saw us as a way to improve their performance in MSDs. So that was part of it. But the actual managers on site are chefs. In a lot of cases, the chef is the person who's in charge. I wouldn't say that they actually felt it was necessarily a hazard. They wanted to just do their work and get it done. So that was more their focus, I would say.
That was reflected in their symptom surveys too, right? You're mentioning 1s and 0s from the staff.
Yeah. Huh. Sorry, I think there's a question at the end.
Considering you were targeting a vulnerable group, can you elaborate a little bit in your approach to the training method that you used? How do you know, or could you tell that there was comprehension considering the audience?
So in the training, we used a variety of training tools. So the training was very interactive. So there wasn't a lot of talking. There were slides that had information on them, but we had a lot of discussion and talking so that we could test, like, how are they doing, where are they getting it? And we had some challenges when we were delivering the training, even getting people to engage in it. That was one of the challenges that we had. But we also had video to support, so we talked about it, we discussed it, they saw the pictograms, and they saw video. So there was lots of visual cues as well. It wasn't just the pictogram.
And just from my memory of looking through the training, correct me if I'm wrong, but didn't you also ask the participants to identify things specific to their workplace and how these pictograms might relate?
Yes. Yeah, so there was a whole component that was part of the discussion. We tried to make it workplace specific. So prior to going into the training, and thanks for reminding me, we actually talked to the supervisors that we were going into their workplaces to find out what were some of the things that they specifically did in their workplace so that we could talk about that. We found out how they reported hazards, so who does the worker talk to report hazards or if they're having trouble, and that was built into who do I go talk to. And then the very last part of the training was what am I going to do differently. So they had an opportunity to work with me and on a small action plan. So I'm going to use my cart every time I move stored food. So they had an opportunity to identify actions they could take on their own to go back to the workplace.
Okay, and then there was also this issue of workplace culture. In both of our experiences, we felt that this was really a culture that's not readily admit to pain or discomfort. And we can't say for certain why that is. We can only make assumptions, and these are some of the things that we both independently came up with, and they seem to ring true to each other. So these injuries, pain, discomfort, sometimes burns or other cuts, these are all seen as a badge of honor in this industry among this population. There's definitely also a bit of a fear of job loss from creating a poor relationship with management or coworkers. There's definitely a couple of experiences where an individual not a part of the study had previously been injured in the workplace, and so were assigned new duties, and they were an outcast among the group. It's like, oh, that this person is taking it easy because of their injury, and sort of mocked for it. So there's definitely this discouragement of speaking up about your injury. And again, we're working with a number of people who come from different countries, and perhaps this is not a common practice in their country of origin. The pace of work does not allow for alternative work styles. So again, with these individuals who have previously been injured and perhaps can't be as mobile as some of their coworkers, they're assigned to tasks that they can really work at their own pace, whereas others are working at just-in-time sort of delivery. And then again, there's this limited knowledge of steps and procedures to address these concerns. So this comes back to people coming up to me and saying, well, if I hurt my shoulder, who do I talk to? And it's it's kind of difficult to address that because I'm there strictly for a research study and I can't guide them through the proper channels. And to be completely honest, I don't know what the proper channels are for that individual in this workplace. The best we can perhaps advise is to speak to your manager, but even that, there's this definite sense that they don't know what they need to do when they're injured.
Even though we covered it in the training, they still, like Trevor was going in after the fact. So either the people asking the questions were the people who left early, or there just really was this misunderstanding of what do I do if I'm having trouble.
And other individuals not even associated with the study, but they see that I'm a foreign agent in their workplace and they think that I'm associated with something else like the WSPS or the Ministry of Labour. So just to wrap things up into our conclusions, again, this was a collaborative effort to address a serious need in Ontario's workforce. The participatory approach to creating the pictograms was seen as a success and will definitely be used in future work. There were some serious limitations in the training component and in the measurement tools used in the intervention, so we're looking to revise that. Despite the numerous challenges, the findings do suggest that this is a promising intervention for this population, so we'd like to move forward and do more work in this area. Further work is required to refine both the intervention and the evaluation tools for a high-quality randomized control trial, and this is actually underway right now through a development grant from the WSID RAC, specifically for the hotel-motel sector. So we're looking at all of those tools again, we're looking at the training, but we're gearing it to a new service sector, with the hope that it will go to a larger randomized control trial. And I think we were taking questions all the way through, but I think we're almost out of time.
We've got time maybe just for one or two questions. Cam.
Thanks.
Was the pictogram series developed for warehouses and for greenhouses?
Yeah. So we have developed warehouse pictograms, we've developed greenhouse pictograms and retail pictograms, and we're developing a corresponding training program for each of those sets. And all of this material, we were waiting for the study to be finished, but all of the material will be up and available for workplaces on HSO website. So workplaces can download and print off the stickers and get the training and use it in their workplaces.
I had a question about, you said when you went into the workplaces that some had a really strong workplace employee-worker relationships and others didn't.
Yeah.
I was wondering if you stratified your results in terms of the hazard identification follow-up over time by that.
No, we didn't actually. We didn't even consider that. So I didn't record. I could probably go by memory as to which sites were which. But no, we didn't think about looking at it that way.
Okay. It'd be interesting to see maybe if your training actually works in the workplaces that had a good relationship.
Yeah, relationship. Yeah.
You may want to think of this different training approach for workplaces that don't.
Yeah, that's great.
That's a good idea.
I'm wondering about reinforcement. If you decide to do the trial for longer, do you consider having, like, say, at a 3-month point, some kind of reinforcement training or reminder training about something?
I'm not sure. I mean, I guess it depends on what would be feasible in an organization. Are these steps that you would need to take in order for this intervention to work, and is it realistic for the workplace? I think ideally we would like to perhaps just do the training once, and then the pictograms are a constant reminder, and then perhaps every time you have a new employee, you conduct that training, and then anyone else who wants to attend would attend as a reminder. But that's just off the top of my head.
From my perspective, it would be great if they did the training once. So I think that is a bit of a win, especially when it comes to MSDs, because they don't recognize the hazard necessarily in the workplace. So even finding out if that has some change in work practice, that's great as a start. But
all right, so I think this was a really fascinating, and it sounds like an incredible learning experience in terms of the challenges of implementing an intervention like this with a vulnerable population. Thank you for a very clear and informative presentation.